fluid
I don't know how to do
in little space.
Wow. Broken ribs. I was gonna touch it.
I thought it was
It's 3. I know. I just
Is it triple double? Yeah, 3.
in 2 or more places.
3 years.
Yep. Okay. So just to review, we're going to compare and contrast these to make sure you understand how to tell the difference between the two. Then I'm going to show you how to do the chest tube setup with the Plurivac. It's actually pretty simple. So, so our X-ray is going to be black and deviated trachea away, pushed away from, affected side. Right, so pneumos push, atelectasis attracts. So this is going to be white in the affected area, deviated trachea towards the affected side. This is going to be white with no claustrophrenic angles. If there's any deviation, it's also going to be pushed away because of all the fluid. And here you're just going to see the broken ribs. So that one's not really. Percussion note, hyperresonant, you might also hear it called tympanic, dull, dull, NA. I know, I'm just going to put a name tag on them.
We'll make that one safe for sure.
So when you see these, especially on your testing, it's not so much foil test. I'm just putting it up there to make sure we talk about it. But between, especially pneumo and atelectasis, you have got to pay attention to what the information they're telling you, where it's at, what's pushing what way, and what percussion note you have. We just were going over Sims today, and the patient had a diminished breath sounds on the right, tracheal deviation towards the affected side, and half the class gave the patient a chest tube because that had atelectasis. No, they killed him. He died. Let's see. So what are we gonna do for a pneumo? Okay, so if it's greater than 20%, they're gonna get a chest tube. That takes up more than 20% of the lung.
Oh.
So the bigger, once it gets to 20% of space, then so it's taking up half of the lung cavity, then they need a chest tube. Yes.
That's where you guys figured out the percentage, right?
What?
You figured out the percentage?
Yeah, from the X-ray.
It's true that it's not always gonna deviate though? If it's-
Correct.
Okay.
So, tension pneumos. So you might have a pneumo that doesn't deviate, but if that's on the test, then it would be looking at other things. They definitely deviate. So for tension, we could put severe deviation, because you might have some. Accompanied by hypotension. So when your patient has a pneumo and they become hypotensive, the air is now compressing the heart so much that the heart can't pump anymore. And so that's why the blood pressure drops, and that's why it's an emergency. Because if you don't release the pressure, the heart is gonna stop beating because it's not gonna be able to pump effectively. And the patient will die. So this is life-threatening. That's why we need to do what?
Needle decompression.
Needle decompression. Where?
And then
Nope. Second and third. You're all wrong. Oh, but if you want to put this over on this side, this is in the 5th intercostal space. 5th.
So the tension, that's the third and fourth?
Second and third.
Second and third. And then the other one is what?
5th. So above the 3rd, because remember the arteries are below the rib, so you have to go above. So needle decompression, mid-clavicular, between the 2nd and the 3rd. Chest tube is going to be the 5th intercostal space, more mid-axillary, what they call that, the triangle area. What do we do for atelectasis? Yeah, so I'm going to talk about you talked about hyperinflation and atelectasis as a term too. So let's look at this more of like an ICU patient with a lot, like half a lung, an entire lung. So large amount of lung affected. What's something that would cause a large amount of atelectasis?
Too much pain.
Too much what?
Pressure.
Too much pressure is not going to cause atelectasis. That would cause a pneumo.
Sedation.
A mucus plug, a huge mucus plug.
Oh, wait, I think
Anything that's lost?
What about a right main stem?
Oh, yeah.
thing is gonna be secretions from like a mucus plug, but it also could be like a foreign body. Foreign body, you're gonna need a bronch. Right main stem, you're gonna pull the tube back. Mucus plug is either gonna be bronchopulmonary hygiene or a bronch, depending on how severe the patient is. But they will order stat bronchoscopies done in the ICU to patients, because if your entire lung is collapsed due to a mucus plug, your stats are gonna be horrible, your patient's gonna be in distress, they're not gonna be doing well. You'll get an x-ray, you'll see a total whiteout on one side, and they'll order a stat bronch, you'll go in and you'll just see tons and have to clean them out, basically. You're gonna go in and do a bronch and clean them out.
What does that mucus plug be?
Bronchopulmonary hygiene, BPH, or a bronchoscopy. What are we doing for this? Thoracentesis. You would only do a chest tube if it's a large amount of fluid that is like recurring and they can't get it. Like and sometimes it will be like that from like a hemothorax when you get blood. So, but normally we're gonna do a thoracentesis.
Apologies. We need to finish recovery.
What's the other x-ray that they'll sometimes use for a pleural effusion?
The side one.
What's it called? Lateral. Not just a lateral. A lateral is looking at it from the side. A lateral decubitus.
Oh yeah, I flipped them on the side. Oh yeah, to see where the water goes. Or the fluid.
And then what do we do for flail chest?
Let them heal.
Yeah, wait.
Yeah, a lot of it's going to depend on the severity, but we can do splinting. We can do CPAP / PEEP if they end up getting intubated, depending on what's wrong. What can this also lead to?
Atelectasis, pneumonia.
Pneumo more than anything. So I would put watch for pneumo. And they may even have to do surgery when they're wire things back together. Not anything I ever want to have done. Oh, thank you. Okay, I'm going to show you a video.
Is it a long video?
Huh?
Is it a long video?
No.
Okay.
Why?
Should I record it? I don't know if I should stop it or just continue.
Oh no, I would stop it.
Okay.